Hi, good morning, everyone. Thank you so much for attending this morning's Breakfast at SSCY seminar series. I'm very excited to let you know that there's 68 attendees that are registered this morning, so that is great news. Dr. Leslie Roos is just setting up, so while she's getting her computer up and running, I just wanted to begin by introducing myself. For those of you that don't know me, my name is Elizabeth Hammond, and I'm a physiotherapist and research coordinator here at RCC. Before we begin, I would like to acknowledge that we are on Turtle Island and that this is Treaty 1 land and the traditional territory of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. Today, as you know, I'm pleased to introduce Dr. Leslie Roos and Sandra Hunter, who will be co-presenting on today's webinar, entitled Disrupting the Intergenerational Transmission of Mental Illness and Developmental Inequities. The BRIDGE program that stands for Building, Regulation, and Dual Generations began here at SSCY Center approximately 1 year ago. This presentation will discuss the one-year pilot results, as well as the next steps in group-based telehealth and mobile health options for addressing maternal health needs. Dr. Leslie Roos is an assistant professor in psychology and pediatrics at the University of Manitoba. She aims to support child health and development needs by developing programs that promote maternal mental health and responsive parenting. Dr. Roos is also affiliated with the Children's Hospital Research Institute of Manitoba and is a junior fellow at the Harvard Center on the Developing Child, where she consults on program evaluation. Sandra Hunter is an Indigenous master's student in clinical psychology and at the University of Manitoba, and her master's thesis involves preliminary research that will inform the development of parenting programs grounded in First Nations cultural child rearing. Sandra will be presenting on her plans to investigate and document traditional child rearing practices from Indigenous communities in Manitoba, eventually working towards First Nation created parenting programs. We welcome you both to our seminar series. I will now turn the presentation over to Dr. Leslie Roos. And while I organize there, just a bit of housekeeping. So everyone is automatically muted as you come into the webinar, but questions are absolutely welcome. So if you can type any questions that you have throughout the presentation into the chat box, I'd be happy to pass those on at the end of the presentation today. This session will be video recorded and posted on the RCC website to share with families and for those that could not attend virtually today. So over to you, Leslie, if you're ready there.
Roos. I am a professor in the departments of psychology and pediatrics, and I am thrilled to be presenting this today along with Sandra Hunter, who is a clinical student who has been involved in this research and is also leading her own program of research on Indigenous family wellness. So child mental health, as many folks here likely know, is quite common and has many consequences. So up to 13% of children worldwide experience mental illness, and that includes in countries such as Canada and the US and globally. Importantly, mental health problems are even more common in children with neurodevelopmental disorders, with about 30 to 50% of children having additional mental illness comorbidities. And that is true across neurodevelopmental disorders, so including autism, pervasive developmental delays, ADHD, and other challenges. So early mental health difficulties, particularly mental health problems that are prevalent or that come online before about age 6, lead to a number of health risk behaviors later in child development and life. This can include things like aggression, like substance use, like suicidal ideation, and overall child mental illness is linked to low quality of life, even beyond many chronic physical health conditions. Maternal mental illness really plays in here for many children in that it both increases the risk that children have if they have early onset mental illness and increases the need for family supports. So in terms of risk, if children are exposed to maternal mental illness at any point following birth, they have about a 400 increased risk of developing mental illness themselves. Maternal mental illness is also linked to developmental delays in language, attention, cognitive development, and fine motor control. Notably, these risks are present whether or not a child is exposed in utero or the year postpartum or any time in the first 5 years of life, although there's slightly different risks for different disorders based on the time of exposure. The links between maternal mental illness and children's developmental challenges and mental health and behavior challenges is particularly exacerbated in the presence of household adversity. So managing poverty, housing insecurity, family violence, or domestic conflict, along with the presence of prolonged mental illness. So the really strong effects that link maternal mental illness to child development occur when maternal mental illness lasts for more than 1 year or when there's multiple episodes. So it's really that repeated exposure to maternal mental illness, which from my perspective advocates for the importance of addressing mental illness when it is a relevant clinical factor. In early childhood, there's increasing evidence at about age 2 to 5 years of age, exposure to maternal mental illness has major effects on child development. And this is particularly important because much of the attention on maternal mental illness to date has been in the perinatal period, so during pregnancy and postpartum. And although that period is certainly important, there's a lot less screening and programs that are designed to serve parents of children in the preschool years. One other thing I want to note here is that these effects can also be, bidirectional and have genetic components. So we know that when children have behavioral challenges, that can increase parenting stress. And there's also genetic factors that might put mothers and children at increased risks. Nevertheless, we know that there are very important environmental pathways of exposure. This makes a lot of sense because families don't exist, in a vacuum. They exist in their homes and in their communities. And many of the same stressors that might also increase a mother's risk for mental health challenges might increase their child's risk for mental health challenges. And chronic stress is something that I pay a lot of attention to in my research. So sort of early childhood adversities, exposure to racism, exposure to neighborhood violence, exposure to poverty-related stress. But across adversities, the one factor that we know is really, really important for promoting child resilience is a close relationship with a primary caregiver. It's most often the mother. And that relationship sort of looks different depending on your clinical orientation. You might talk about it in terms of strong attachment. It might be highly sensitive parenting or responsive parenting. But it really is factors about that relationship that the child has with a primary caregiver that is protective. Because of the importance of that relationship, a lot of the attention in maternal mental illness treatment has gone towards promoting positive parenting, because way through which maternal mental illness results in subsequent child developmental challenges. And so there's lots of parenting programs out there. I believe that some of these might be offered at SCY, or they might be referred to other families, things like Circle of Security, Incredible Years, Triple P, other parent management training programs, or Tuning into Kids. And about 50 years of research on these programs has been really positive in showing that it can move the bar. But one thing that we see in the data, and this is from a meta-analysis that a student that I work with led, is that the program's effects are modest. So this is looking on the x-axis at year of publication from the year 2000 to the year 2020. And on the y-axis is effect size. So 0.2 to 0.6 is generally considered a small to medium effect. So the good news is that most programs seem to change child outcomes, so improve child mental health and behavior on average. And there is actually a trend for increasing effect size over time on average. So that is really positive that group-based parenting programs can change outcomes for kids and families. But I think that what most folks watching this webinar might agree with, and that I have also experienced clinically, is that we often hope for more for our families. So it's really wonderful when we can offer them programming that we think will make a difference, but we often want to be, helping kiddos out more, helping parents out more, and improving those outcomes more than just a small or medium effect, but more sort of a big effect to really improve their ability to sort of achieve their goals in a way that's consistent with family values. So in terms of those limitations, there's also some additional limitations for families with maternal mental health challenges. So parenting programs often under-enroll and underserve mothers with maternal mental illness. That can include early dropout or under-enrollment to begin with. Programs that are directly for adult mental health, so referring mothers to mental health treatment, are often inaccessible to parents due to challenges like childcare or meals. And adult mental health programs rarely transfer skills to the parenting context. And that can be relevant because, as many folks may know who work with small children, who have small children of their own, there's nothing like a toddler tantrum to really increase that stress and increase your frustration. So I think my experience has been that transferring mental health skills and self-regulation skills to the parenting context can be particularly valuable. There is some promise, so some emergent programs are simultaneously addressing parent mental health and child mental health needs, with an early meta-analysis suggesting that programs that address both can increase program efficacy and child outcomes by up to 50%. So where do we go from here? In the Hearts and Minds Lab that I co-direct, we focus on program development innovations, the first of which is gaining precision in understanding the underlying mechanisms that are disrupted by early adversity and stress exposure, and that can be remediated through early intervention. And also an attention to really supporting those dual generation capacities linked to mental health and development. So if a mother has mental health needs and a child has mental health needs, trying to support both to really increase the resilience of the family unit and increase a mother's capacity for supporting child well-being. And the importance of this was really relevant to me clinically. I spent many years providing supports for families involved in child welfare services, and they were specifically parenting supports. And although these supports, were, I thought, quite effective and very important, it often didn't seem like quite enough, or it could seem invalidating sometimes to emphasize that parents needed to be changing their parenting when they had all of these needs that we weren't simultaneously addressing. So that is sort of another factor that's motivated this work. The Bridge program is a program that we'll focus on today, which stands for Building Regulation and Dual Generation. And it works from this model that self-regulation, sort of referring to regulations of one's behaviors, emotions, and physiology, can really be linked to maternal mental illness and parenting. So it's really hard to stay positive and to parent in a proactive, emotionally supportive way when you are really overwhelmed with your own emotions. So that self-regulation related to mental illness can affect self-regulation and parenting. And the combination of maternal modeling of emotional dysregulation combined with parenting that might be less sensitive or harsh in some situations can lead to self-regulation challenges in the child, which over time can impact mental health, physical health, and achievement. We do focus on trying to narrow in on exactly how these pathways are transmitted in families. One way that we do that is that we do a mild acute stressor in children in the lab. So they play a matching game that's quite challenging, but they can't do it enough time. So they fail multiple times and then fail to win a desired prize. They do get the prize at the end of the visit, and families are aware before coming into the visit that their child will be doing this, and occasionally parents will opt out. But after the stressor, mothers come in and play with their child, and they're told that they just did a frustrating task and are suggested that they support their kids, as they normally would. And what we see in the graph on the right is for mothers with lower symptomatology of depression, they're represented in that blue line. And we're looking at the stress hormone cortisol here. And what we see is that when mothers are present immediately after the stressor, you don't see that rise in the stress hormone cortisol, which reflects sort of widespread activation of the body's alert response systems in response to acute stress. So children tend to just decrease their cortisol over the course of the visit. However, in mothers who have more severe depression, and this is based on clinical severity, in that highest category, what you see is their children still do exhibit that sort of full body stress response following this laboratory challenge, and that it's not buffered by maternal presence. So one of the things that we're doing in the Bridge program is we're trying to understand through video coding those interactions, is looking at individual differences in parenting, so different types of parenting strategies that might help children better cope with stress. One of the things that we think is relevant from a related task that we did is really the maternal touch. So parents might try to distract their kids, which can be positive from an emotional perspective if they can move on. But mothers who are first able to really comfort their children, have them come sit on their lap, provide that physical touch, that seems to be really potentially a potent factor in increasing children's ability to regulate to stress over time. In terms of the program itself, we are looking at intervening on processes that underlie stress management and self-regulation in parents and kids. So in the short term, that looks like addressing symptoms of maternal mental illness to build emotion regulation. We also look to increase supportive parenting practices, so that physical comfort, emotional validation, also just positive activities. We also work to increase mothers' social support and reduce stress. So providing a group-based venue to talk about emotional challenges and challenges of parenting, and providing real skills to reduce stress over time, so to improve stress management in the challenging situations that are often present as a parent, either directly with your kid or potentially in working with social service providers. The long-term aims are to improve family mental health, stress management, and relationships, to increase children's self-regulation abilities and cognitive development, and to prevent later life mental and physical health problems by intervening in the earliest years of life. So we intervene with Bridge right now from about age 3 to 5. We have the potential to expand that age range as well. One of the first things that we did with the Bridge program is that we did some focus groups. So we talked to families at Wolseley Family Place to ask if these topics were relevant, if the content was relevant, what they wanted more or less of. And what we heard was that these topics were relevant and that mothers did want to talk about these topics. So one mother said that I want reassurance that he is safe, that home is safe. Another mother said, I worry that my mental health challenges will impact my kid, so talking about this is important. And another mother with multiple kiddos described that she didn't like when they stayed inside all day. She said, I feel guilty, I want to take them to fun places and really have more juicy parenting, And that idea of juicy parenting, that like really rich, engaged, fun, highly attached, enjoyment of the parent-child relationship, I think really captured what we hope to promote in Bridge, is that sort of fully engaged, having fun, mutually reinforcing relationships. So we target maternal mental health using dialectical behavior therapy skills. It has 4 core components, which are mindfulness, emotion regulation, interpersonal effectiveness, and distress tolerance. DBT is evidence-based across a number of different mental health challenges, which is one of the reasons why we use it in Bridge. So it's effective for depression, it's effective for traumatic stress-related disorders, it's also effective for substance use, as well as personality disorders such as borderline personality disorder. And the value of that is that my experience clinically working with parents and the evidence suggests that many mothers have challenges across a number of domains. So DBT isn't just addressing the cognitions related to depression, but it's addressing those cognitions in addition to managing self-regulation and impulse control, and helping parents to bring in relationship support from other folks in their network. And it really uses this dialectical approach that is inherently validating for the many challenging experiences that an individual has faced. So that acceptance piece, while also advocating for change. So despite the fact that we might be doing the best we can right now, that we're going to need to bring in more supports to build more skills, to do things differently if we're looking to improve our mental health over time. An example of this is the STOP skill. So this is a skill that we're supposed to use if you experience a really, really strong emotional urge. So you've just asked your child to clean up for dinner, and maybe you go into the bathroom and there's toilet paper everywhere and in the sink and everything is a total mess. You might feel a really, really big emotional urge to yell at your kiddo, or to say, you know, we're not doing dinner right now, this is ridiculous, we have to figure this out, and really, really become sort of dysregulated or upset. So STOP allows us to not do anything right now, to first notice our emotional state, and then literally take a few steps back to figure out what we want in the situation, what we need to do right now, and how to proceed mindfully. We had a parent describe a situation for using this skill when her child was just finishing dinner and poured a glass of orange juice all over his mother's dinner plate. And she was so frustrated and was really tired at the end of the day. And she used the skill to take a step back and then started splashing her face in the sink with cold water. And her son was like, what are you doing? And he was so confused, and he was so sort of angry and frustrated before. And she described this being a really nice situation where she didn't need to do anything to get her son to start apologizing, to start cleaning up. He was so confused about why she didn't react in a strong way to him. And it really showed her that she didn't need to react in a really harsh way or in a sort of yelling way when her child exhibited a misbehavior, that she had other choices. We also focus on self-regulation via the parent-child relationship, as I've mentioned. So really working on increasing those fun activities. We provide lots of different positive activities that are aligned with these emotional communication, positive interaction, child compliance, and stress reduction modules. This is an example of one page of our activity book, which is looking at making your own animal ears and either going outside or pretending to be animals and trying to identify what different sounds are that you hear. So engaging in fun play-based activities. Year one, we have promising results. So in terms of recruitment retention, we had 28 mothers enrolled in 3 months, and 85% of them completed. And that includes, so the 4 mothers that dropped, 2 of them dropped after just 1 session. So the completion rates are closer to 93%, not accounting for them. We also were able to recruit families who are managing significant additional stress. So the median household income was $20,000 to $30,000 a year. About 50% of our families were single mothers, and many had multiple children in the home. We also had 3 agency partners, including Wolseley Family Place, New Directions, and SCY. And I'm so sorry, I realized I just misspelled that. It should be SSCY. And I may have seen many of you. We are up on the 2nd floor here, and we had a very busy crew of a lot of kiddos in childcare and pizza, and just a really fun time spending time with families over the course of the program. In terms of the quantitative results, we saw improvements in intergenerational outcomes. So in maternal mental health, we saw significant changes in maternal depression with large effects, medium effects on maternal emotion dysregulation. Because the sample that came into the program primarily had depression, it makes sense to us clinically that we saw more changes in depression. In the parent-child relationship, we saw decreasing parenting stress, and decreasing parent perception of child mental health problems, also at a large effect. One thing that was also interesting about these results is that we saw that mothers who had higher adversity experienced particularly strong decreases in parenting stress over time. So we're looking here at a mother's own experience of early adversity. So mothers who had higher early adversity tended to have more declines in parenting stress over the course of the program. This was also true for mothers who'd had more past year stressful life experiences. All right, so with that, I'm going to switch over the audio to Sandra. Sandra, are you there? How is your audio doing?
Hello, can you hear me?
Yes.
Okay. So I don't know if I can share my webcam. I will try that also so that everyone can see me. And I am a graduate student that is working with her in the lab. So the quantitative results have shown that 85% of mothers reported a clinically significant reduction in depression. Okay. And then, in addition to quantitative results, we also did some qualitative studies. So these were individual interviews post-program. So we really wanted to hear the perspectives of how the program impacted the mother's mental health. Here you can see that there are 3 main themes for mental health, and we've included some quotes. So the moms said that they experienced an increased ability to manage difficult emotions. So I'll just read this one out quickly. I would just like steam in my head. So now I just take a deep breath. I find a better way to respond. I think, or like my responses have changed. Like I don't feel that angry feeling so much anymore. The moms also said that they experienced an increased ability, they experienced an increased sense of social support. So the quote here is, it was just nice knowing that there were other women going through the same thing as me, and everybody has different situations at home and dynamics. They also experienced a positive influence on their relationship with others. The program has helped me to step back and let my husband do some things his way. It's given me some of the skills and how to deal with it more, of the like, just shut up and just let it happen. Okay, advance. So switching back just briefly to the quantitative results, 93% of children exhibited declines in mental health and behavior problems. And then back to the qualitative results. So we wanted to hear from the mothers their view on how the program impacted their parenting. Again, here you can see 3 main themes. The mothers said that the program made parenting feel rewarding. I think that I actually really enjoy spending time with my kids. And for a while, it wasn't enjoyable because it felt more like a job. They also said they felt it helped with child development. Being able to talk to their children about their emotions, their ability to communicate back with me, it's like they're less scared of me. And then also an increased sense of competence with the development and teaching them lifelong skills. I've taught them something that is going to be a really good skill later on in life. Okay. Another important theme we heard in the interviews was that the mothers really felt that the program had changed their interactions with their children. It's unfortunate that you can't hear the pride or relief in their voices because of this change. So here are some examples of what they said. So I'll just read out this 3rd quote here. Nobody's stomping away, or we just don't stop talking to each other. It feels like we're able to work through those rough spots. And so I think having done the interviews myself, I think what I felt from them during those interviews really was a sense of hope and belief in themselves after going through the program. It was quite a powerful experience to listen to them and hear what they had to say. Okay.
So I'll jump back in terms of our year 2 plans here. So due to COVID, we're not able to do in-person groups, particularly because we heard from our parent advisory panel about how important childcare was. So instead we moved to a telehealth model. And we're looking at 2 different models now, which have been informed by parents who took the program last year, advising on what they think would be effective. So in one model, we'll be doing standard telehealth therapy, just a 2-hour group where people are listening in and participating, that is moderated by clinical psychologists. And the second one is a self-led therapy and social support group. So we heard from some parents that they didn't think that finding 2 hours, to put in earbuds meds and to participate would be feasible. So instead, they'll be walking themselves through the material. That we'll do some short pre-recorded sessions, and then they'll follow up with just a 1-hour group to review the material, to ask questions, and try to have that sense of social support. Our goal here is that if self-led therapy is similarly effective to standard telehealth therapy, that could be really informative for future scalability efforts, because some of the aspects of the pre-recorded didactic teaching might really help with reaching a larger number of parents, and then just doing those smaller social support groups afterwards. We've also, although we've heard some challenges about not being able to come in, many families from more rural areas or who have challenges with transportation, I know in the middle of the winter it can be quite challenging, have talked about really looking forward to this model of telehealth. So we're looking to see how it goes, and then we'll also have the year 1 results to compare these updated telehealth models to. We're also doing some adaptations for different family needs. So we have many families from SCY who are involved with the program, but right now, if a child who is in our age range is sort of nonverbal or has major language delays, and they're not eligible for the current program because we're concerned that the materials aren't quite a good fit right now because they are quite language based. So this year we are still including those programs, including those parents. They won't be part of the technical research here, but we're going to do a separate project that is looking at adapting the materials to family needs and working through the program with families to hear about what's relevant and what might need to be changed as well. So I will now let Sandra go ahead to talk a little bit more about some of her work.
Great, thank you, Leslie. So Leslie has asked me to talk a little bit about my work as well. So I am building on my training in clinical family psychology to support intergenerational mental wellness with Indigenous families in Manitoba. So my project is special to me because I am an Indigenous mother and want to take all of the opportunities that I can to help others. Can advance. Thank you. So I just want to give a bit of a historical context. We know that many of the struggles for Indigenous people today are a result of intergenerational trauma resulting from government policies. In 1884, the government made Indigenous cultural practices illegal through the Indian Act. This resulted in a lot of those practices being hidden and a reduction in passing down knowledge. From the 1880s to the last residential school closing in 1996, and in the 1960s, with the 60s scoop, children were forcibly removed from their families. So this created acute trauma from the apprehension for both the parents and the children. It also created long-term trauma from the separation, and many of those children experienced horrific neglect and maltreatment. These experiences created a cycle in which the children were modeled abusive care. They had also lost the influence of their own cultural parenting practices. And when they became parents themselves, they were hurting, and they raised their own children as they were raised, and through all their hurt, beginning a cycle of intergenerational trauma. So the situation is not much better today. There are still ongoing present-day harms. Many families are living without their cultural practices. They're experiencing a cultural identity crisis. The children are still being removed at an alarming rate. And there are a lot of other policies in place that continually discriminate, such as poor education funding and racist policing. Okay, next. Thank you. So knowing about the cycle, how do we break that cycle? So the Truth and Reconciliation Commission of Canada has looked at this extensively. They released some calls to action in 2015 to try to mitigate these harms. So 2 of these are the focus in my project. The first is number 5, which is to develop culturally appropriate parenting programs, and also number 19, which calls for closing the gaps in health outcomes including maternal health and mental health. Okay. So this is sort of a summary of my projects. So I'm intending to do 3 projects to accomplish those goals of mitigating harms. The first project is what I'm working on this year, and that's to interview traditional knowledge keepers in Manitoba. I want to find out what child rearing practices were used pre-colonization, because though many of the ceremonies and practices were made illegal, this knowledge went underground. It was hidden and protected and is now experiencing a resurgence. I understand that this research needs to be done in an ethical and safe way, so I want to make sure I'm honoring traditional protocols. I'll be using methods which will allow me to honor Indigenous ways of knowing, with a focus on meaning making, and also utilize Western ways of knowing by analyzing the interviews using a qualitative thematic analysis. The other 2 projects will involve participatory action research with Indigenous families. It's as a needs assessment, and to eventually create a culturally based parenting program that is Indigenous created and led. By reclaiming traditional parenting practices, it can strengthen pride and cultural identity, strengthen intergenerational support systems, which will eventually promote family wellness and keep families together. That's it.
Wonderful. So that is the end of our presentation today. Thank you so much to the many families who have participated in this work and our Hearts and Minds Lab team, some of whom are pictured here. I've also put our lab website, heartsandmindslab.com, and Sandra's email and my email up here as well.
Thank you so much, Dr. Roos and Sandra, for that wonderful presentation. Your research is really exciting and really interesting. And Sandra, it's so important to look at that colonization-linked health inequities and the intergenerational trauma that is continuing. And I really look forward to having you back at Sky Center to hear your results to promote those traditional Indigenous teachings